From Microbe TV, this is Infectious Disease Puscast, episode 44, recorded on December 20, 2023. I'm Daniel Griffin, and joining me today is Sara Dong. Hello, everyone.
Hi, everyone. This is Sara Dong. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. I realize this is sort of like our holiday recording. I should have had a Santa hat or something festive to bring.
Actually, that's true. This is going to come out right around that December holiday. And yeah, what do I have like a coronavirus bow tie instead of something more appropriate and festive. And Sara, you did the last Puscast all by yourself.
I did. Hopefully it went okay.
No, I enjoyed it. I actually listened to it, and good stuff. A little too good, right? You hate to feel superfluous, but it is good to know. Good to know.
I don't think that's so. Oh, well, everyone knows this is Puscast, a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we?
All right. So viral, remember to listen to This Week in Virology, both the weekly clinical update and the deep dive. And I will start with an article that is really a warning for clinicians along the lines of Occam was not a doctor and a patient can have as many diseases as they please. Mpox and chickenpox co-infection, case series from southern Nigeria, published in JID. And it turns out that in this retrospective cohort analysis of patients with Mpox, 28.6% had a co-infection with chickenpox. So you see those vesicles in multiple stages of development and you think, all right, this is just the good old CPOX, I'm renaming that, and you can now just move forward. But if you don't bother to test and you move forward with the confidence of, I like to say, a feral dog, next thing you know, others are getting the Mpox. Lo and behold, it just reinforces how important testing is to confirm our medical diagnoses.
Yeah. I pulled a paper from the Annals of Internal Medicine. New clinical guidelines were published. Prevention, diagnosis, evaluation, and treatment of hepatitis C and CKD. Synopsis of kidney disease, improving global outcomes, 2022 clinical practice guideline. So this is an update from a guideline from 2018. And I just have pulled out the key changes because for a majority of the other recommendations, they are unchanged. But the main ones are first, for treatment of hepatitis C in patients with CKD, the guideline now recommends expanding treatment with sofosbuvir-based regimens.
That was excellent. That
I'm
was
like
well
a
done.
1 out of 2 chance. They do recommend starting treatment for patients whose GFR is under 30, including those who are receiving dialysis, whereas previously it recommended not providing treatment at those lower GFRs. For management of hepatitis C before and after kidney transplant, these guidelines officially endorse expanding the donor pool for kidney transplant recipients by suggesting that we should accept hepatitis C positive kidneys regardless of the recipient's Hep C status. So the prior guideline recommended that Hep C positive organs should be directed to recipients who are also hepatitis C positive. And then for diagnosis and management of kidney disease related to hepatitis C, the guideline recommended that Hep C infected patients with a typical presentation of immune complex proliferative glomerulonephritis can be initiated on direct-acting antiviral treatment without a confirmatory kidney biopsy. And then another new change was patients with cryoglobulinemia flare or rapidly progressive glomerulonephritis should be treated with both antiviral agents and immunosuppressive agents with or without plasma exchange. And then they suggest that the use of immunosuppressive agents in patients with nephrotic syndrome should be individualized. It's just like a slight adjustment in the language to give a little bit of space for people to decide for case-by-case basis. But a couple small adjustments, things that I suspect people were already sort of doing, but now you have a clinical practice guideline to back you up.
It's nice to see like the pretty rapid update, right? 4
Yeah.
years. I mean, yeah, things should be updated. Like, I hate when I see like, and 12 years ago, we used to say, it's like, oh my gosh. All right. The article, corticosteroids for preventing post-herpetic neuralgia, is a Cochrane review. I think our listeners may know that I'm a little bit ambivalent about reviews, particularly those Cochrane ones. But here, the authors updated the searches for randomized controlled trials of corticosteroids for preventing post-herpetic neuralgia in the Cochrane Neuromuscular Specialized Register, Central Medline, Embase, 2 other databases, and 2 trials registers. They also reviewed the bibliographies of identified trials, contacted authors, and approached pharmaceutical companies to identify additional published or unpublished data. All they left out was the gray web, right? They they identified 5 trials with a total of 787 participants that met the inclusion criteria. That's not that many. No new studies were identified for this update, but we're going to provide one anyway. All were randomized, double-blind, placebo-controlled parallel group studies. They report that the evidence is very uncertain about the effects of corticosteroids given orally during an acute herpes zoster infection in preventing post-herpetic neuralgia 6 months after the onset of herpes. Very low certainty of evidence, downgraded for serious risk of bias and very serious imprecision. They conclude that based on the current available evidence, and there's nothing new here, we are uncertain about the effects of corticosteroids given orally during an acute herpes zoster infection on preventing post-herpetic neuralgia. Now, fortunately for those folks that like to do something, even when it is not helpful, because they seem unable to keep their hands in their pockets, they did not find compelling evidence for significant harm. So the basic side effects and costs of giving those steroids unnecessarily. And I must say, like, people like giving steroids, Sarah.
They do. Yeah.
They really do.
Yeah.
All right. The article, Alarming Trends in Dengue Incidence and Mortality in Bangladesh. That's quite a title. Was recently published in JID and really does a great job of pointing out the explosion in number of dengue cases throughout the world and the rising number of deaths. Just to read a bit of the abstract, Bangladesh is currently experiencing the country's largest and deadliest dengue outbreak on record. This year's outbreak has been characterized by an early seasonal surge in cases, rapid geographic spread, and a high fatality rate. The alarming trends in dengue incidence and mortality this year is an urgent wake-up call for public health policymakers and researchers to pay closer attention to dengue dynamics in South Asia, to strengthen the surveillance system and diagnostic capabilities, and to develop tools and methods for guiding strategic resource allocation and control efforts. All right, and I've got like a run here in a row, and then Sarah's going to take over. But bacterial, this must be withdrawal, right? So be sure to listen to This Week in Microbiology. Best corny title goes to the article, Nut Cracked. Does the ACORN trial and the debate surrounding vancomycin and piperacillin-tazobactam combination therapy and increased risk for acute kidney injury, published in Open Forum Infectious Disease. Now, we discussed the ACORN trial, I think it was a couple episodes back, and in ACORN, the authors concluded that there was no association between receipt of cefepime or piperacillin-tazobactam and the primary outcome of AKI, acute kidney injury, or death by day 14, despite the fact that over 75% of the population received concomitant vancomycin. Now, this article is worth reading. I will suggest reading this with an open mind, as I am not so sure this debate is completely resolved. They do point out that this trial was looking at empiric therapy for possible infection. The average duration of vanco was only 2 days. And they actually have a nice table 1 where they look at comparative rates of AKI as a function of duration of therapy of cefepime versus piperacillin-tazobactam, excluding patients who died in ACORN. And things look fine if you look at any duration. Things look okay, out to about 48 hours or more. But once you start getting out to greater than 96 hours, there actually is a statistically significant difference. So I think the debate will go on.
It is the article title was clever. I will give that. I pulled a paper from the Journal of Clinical Oncology, prospective external validation of the Espen-Shade Vanderbilt models accurately predicts bloodstream infection risk in febrile non-neutropenic children with cancer. So, how can we best know what to do with fever without severe neutropenia? The authors looked at episodes of fever with a central venous catheter in place and an ANC over 500 in pediatric patients with cancer from 18 centers. Among 2,565 prospectively collected episodes, the bloodstream infection rate was 4.7%, so 120. Complications were rare. 1.1% required ICU care by 7 days. The all-cause mortality rate was 0.2%, with only one potential infection-related death. And the C statistics range from 0.775 to 0.789 for predicting overall bloodstream infection, with improved accuracy in predicting high-risk organism bloodstream infection. And C statistics are basically area under the receiver operator characteristic curve. I had to look into. The initial empiric antibiotics were held in 15% of episodes with no death or ICU admission attributable to not receiving antibiotics. They used different versions of this Espen-Shade Vanderbilt or SVAN models, which they've outlined in detail in Table 1, but they focused on the SVAN2B, as it had been prospectively shown to reliably predict bloodstream infections in clinical practice. So just to give everyone some insight, the variables that are included are type of CVC, central venous catheter, hypotension, shaking chills, if they've had a stem cell transplant, upper respiratory symptoms, exposure to chemo within 24 hours of the fever presentation that causes fever, age, their max fever, and their ANC. So pretty cool. I actually don't know that I had used these scores before, but we'll have to think about it more on my next consult.
Okay. Well, I'm not sure how many people are following this, but we get another alert from the CDC about a salmonella outbreak linked to cantaloupes. I don't know if you ever do this, Sarah, but apparently we do this in my group where we all Venmo somebody money and then they buy something nice for our staff. And so last night I'm working late in the office and Mary Ellen brings in this sort of bouquet of fruit and there's cantaloupe in there, right? And I'm like, what are you doing? She's like, oh, this is really nice. You guys bought it for me. Would you like some? And I'm like, I'm not eating the cantaloupe. I don't know where that cantaloupe came from. Why are we getting this alert? Well, as we read, the CDC is concerned about this outbreak because the illnesses are severe and people in long-term care facilities and child care centers have gotten sick. They say, do not eat pre-cut cantaloupes if you don't know whether Malichita or Ruby brand cantaloupes were used. And I did not. They give us some fast facts as well, which I pulled off the web on December 9th. So follow the link for some ongoing updates. We'll leave that in the show notes. But as of the 9th, we had 230 illnesses, 96 hospitalizations, 3 deaths, 38 states reporting.
Yeah, no Christmas cantaloupe.
Yeah, no Christmas cantaloupe for me. And sorry, Mary Ellen, I wasn't involved in the actual selection, just in case you get sick.
Yeah. Well, this next one is a shout out to my awesome and very smart co-fellows who are now big bad pediatric ID attending. So Christina, Nina, and Jeff, and then the wonderful Mari. I miss all you guys. So I pulled their paper from JPIDS, Implementation and Perceived Effectiveness of Prospective Audit and Feedback, and Pre-Authorization by U.S. Pediatric Antimicrobial Stewardship Programs. So the authors use focus groups to explore how the pediatric stewardship programs are using prospective audit and feedback and pre-authorization, and really how they perceive the impact of that on being able to attain their stewardship goals. So the authors spoke with representatives from 24 hospitals who shared the pros and cons of each approach. So, for example, prospective audit and feedback helps uncover trends in antibiotic use and can help with relationship building, but it's very time consuming. Pre-authorization reduces broad spectrum antibiotic use, but offers less educational opportunities for others who are in the hospital. So their findings suggested that a combination of the two strategies could maximize the positive mediators of appropriate antibiotic use. So those are persuasion, efficiency, and pharmacy support, and steward satisfaction, while minimizing the negative items such as opportunity costs, lack of resources, unintended downstream consequences. So I also was going to use this to plug the episode of Febrile 85 called Being a Stewie, because this was a part of the conversation that fits really well, where our guests talk about the core elements of stewardship programs and this sort of compare and contrast of prospective audit and feedback and pre-authorization. So, yeah.
You got to make like Stewie T-shirts. I'm just thinking, let's
I think they have
make
Stewie
let's
pins.
make let's making a Stewie, being a Stewie cool. Now I have to say I really appreciate the stewardship, even if it's just like, hey, the renal function is improving. Just it's great to have another set of eyes. Maybe it's making me lazy. Okay. The article, predictive value of methicillin-resistant Staphylococcus aureus, MRSA, nasal swab PCR assay for MRSA infection in critically ill pediatric patients, recently published in JPIDS. Here are the results of a retrospective cohort study performed in a 44-bed pediatric intensive care unit between 2013 and 2017. 3,860 pediatric patients, 54% male, median age 4 years, little guys, admitted to the PICU, met pediatric systemic inflammatory response syndrome criteria, were screened with MRSA Neris PCR, had cultures obtained within 7 days of the MRSA Neris PCR collection. Predictive values and post-test probabilities of the MRSA nasal PCR for MRSA were calculated. Now, the MRSA PCR was positive in 8.6% of patients. MRSA infection was identified in 40 patients, equaling an incidence rate of 2 per 1,000 patient days. The MRSA PCR demonstrated a positive predictive value of 9.7, but most importantly, a negative predictive value of 99.8%, and a post-test probability for a negative test of 0.2% for MRSA infection.
Nice.
I like that.
Yeah. And then this next one I have is quite short, but I read not only meningitis, but also epiglottitis, an emerging clinical presentation of invasive meningococcal disease in OFID. The title really says it all, but just to give some more info, the authors, who were from France, had noticed an increasing number of meningococcal epiglottitis cases referred to the National Surveillance System, which reports invasive meningococcal disease. So they actually extracted the cases pre and post-COVID. So among 3,024 cases of invasive meningococcal disease, there were 13 cases of epiglottitis. So that's 0.5% of infections. It was distributed as 5 cases pre-pandemic, no cases sort of during the main time period of COVID. I hesitate to say it was like an isolated period. And then 8 cases post-pandemic. All of them were adults who were over 40. They were all associated with sepsis, and Seer Group W accounted for 8 of the 13 cases, but was three quarters of the post-pandemic cases. So just an interesting thing that they had noticed, and I think often people think of epiglottitis as sort of gone since we're not seeing Haemophilus associated Hib epiglottitis, but this might be another thing to look out for.
Okay. The article, Effectiveness of Prophylactic Oral and or vaginal probiotic supplementation in the prevention of recurrent urinary tract infections, a randomized double-blind placebo-controlled trial published in CID. So this double-blind placebo-controlled trial enrolled 174 premenopausal women with a history of recurrent UTIs and randomized them to either of the 4 treatment groups, namely Group 1, which is placebo, plus vaginal placebo, kind of interesting, got an oral and a vaginal placebo, so the double placebo group. Oral probiotic, so this is Group 2, oral lactic acid bacteria and bifidobacteria, plus a vaginal placebo again. Vaginal probiotic, so you're getting an oral placebo and you're getting the vaginal lactobacillus, and the probiotic combination where you get the oral lactic acid bacteria and bifidobacteria vaginal lactobacilli. They do this for 4 months, and the patients were followed up for symptomatic UTIs for 1 year. The primary endpoints were the number of symptomatic UTIs at 4 months, the proportion of subjects with at least one symptomatic UTI, and the time to the first symptomatic UTI. So the incidence of UTI at 4 months in the different groups, I'm going to sort of help you with this. So G1, that's the placebo, was 70.4%. G2, that's where you're just getting the oral probiotics, that was 61.3%, not so impressive. In Group 3, where you're getting the vaginal lactobacilli, that was 40.9%. And in Group 4, that's where you're getting the oral and the vaginal probiotic, 31.8%. So the mean number of symptomatic UTIs was significantly lower. And actually, we saw that progression. Really, the best you were getting is when you were actually doing both oral and vaginal. Probiotic supplementation was well tolerated, no serious adverse events.
Yeah, it's interesting. I've seen a lot of recurrent UTIs this year, like more in clinic than I'm used to, and it is so challenging.
Yeah, what do you think, Sarah, as far as the acceptability? Like, it's very easy to say, "Oh, start taking this oral probiotic," but you read this, and the detail seems to be you need both. You need the oral, and you need a vaginal probiotic.
Yeah, to be honest, I haven't usually really pushed very much for the probiotic. But I would say there's a good number of the patients that I've met that were taking the oral one. I don't know that I had seen patients doing the vaginal probiotic.
Okay.
But interesting. And then I think the last one of this section I have is from Transplant Infectious Diseases, Clinical Impact of Preservation Fluid Contamination on Kidney Transplant Patients. This retrospective study from Spain looked at preservation solution contamination rates for 339 patients who underwent deceased donor renal transplant. They found that 40%, so 136 of 339, were positive for a bacteria, mostly coagulase negative staph, which was 60%. The others, the sort of next two most common were gram-negative bacilli, which is 21%, and then other non-coagulase negative staph GPCs was 12%. Of the 136 positive cases, 30% received some type of preemptive therapy. So that's about 12% of the cohort. There were no cases of UTI, surgical site infection, or graft loss. It seems like the incidence of the preservation fluid contamination that's been reported in the literature is quite variable. Anywhere up to these like reports of 90%. This is somewhere in the middle where they were saying 40%. I think this still makes it hard to know the clinical impact. There are also variable responses in how people are going to recommend if you do preemptive antibiotic treatment, if the culture is positive. I think the one thing that would be agreed upon that makes people nervous is Candida, but I don't know, especially with these bugs, it makes you wonder how clinically important it is. And I don't know that just because all these patients receive preemptive therapy means that it's necessary for us to do it, but hopefully we'll have other studies that can give us a better sense of what to do. All right. And I'm going to move us into the fungal section. I had pulled 2 papers. The first one is from Science Translational Medicine. Zinc prevents vaginal candidiasis by inhibiting expression of an inflammatory fungal protein. The author showed that PRA1 is upregulated in response to local zinc limitation during vaginal yeast infection in mice. In response to zinc limitation, the Candida albicans releases a trace mineral binding molecule called PRA1. And then they showed that the PRA1 gene is upregulated during vaginal infections and that its expression correlates with pro-inflammatory cytokine concentrations. So this was done through an experiment where they had vaginal swab samples from Candida albicans colonized or infected women and those who were not. And then they did some ex vivo human blood chemotaxis model, which showed that the Candida PRA was associated with neutrophil attraction. So if you genetically delete PRA1 in mice, this helped prevent vaginal inflammation. Okay, so now that you have this connection between PRA1 and vaginal inflammation, it's in the clinical setting with the women that they had looked at and the experimental models. The authors reasoned that we might be able to prevent the symptoms of vaginal candidiasis because of the known zinc scavenging function of PRA1. So then they tested application of a vaginal zinc solution and showed that downregulated expression of the gene and blocked immunopathology in a mouse model. And then a pilot study found that use of zinc gel, a gel called Juvia, alleviated symptoms and prevented reinfection in patients with recurrent vaginal yeast infection. So this is like a super simple solution. And I actually didn't know, maybe someone can tell me or send me an email. I was wondering, is this why Desitin is so great for baby diaper dermatitis? Because I think it's just like a zinc oxide type thing. I always thought of that more as barrier preparation to help reduce risk factors for baby diaper dermatitis, like excessive moisture and friction. But maybe the zinc is part of this as well. So I'll just wait till a basic scientist corrects me about all of this. But very cool if we could just use a zinc gel as a tool for recurrent vaginal candidiasis. All right. And then my second fungal article is from OFID, Risk Factors for Invasive Fungal Infection in Lung Transplant Recipients on Universal Antifungal Prophylaxis. As you may know, transplant centers often use universal antifungal prophylaxis after lung transplant. This is a retrospective single-center cohort study that was created to look at risk factors for invasive fungal infection. They included 603 lung transplant recipients from Duke, where they use universal antifungal prophylaxis with inhaled amphotericin B. So they started that in 2000 and continued through 2015, at which point they adjusted to provide fluconazole along with the inhaled amphotericin. And so that's been the regimen in use since 2015. So their lung recipients receive inhaled amphotericin daily for 4 days after their transplant and then switch to weekly use through their hospital discharge or 3 months, whichever sooner. And then the fluconazole is on through about 3 months or 90 days post-transplant. Of course, those who have chronic airway colonization with something that requires a different azole, they are allowed to, they will often adjust that to be more targeted prophylaxis. The authors found that in their lung transplant patients receiving universal antifungal prophylaxis, the risk factors for early, meaning within 90 days, and late, meaning 90 days to 1 year, invasive candidiasis and invasive mold infection differed. They had 26% of their patients, so 159 of 603, who had 182 invasive fungal infections in the study period. Growth of yeast on donor culture and a prolonged length of stay were associated with an early invasive candidiasis risk, whereas transplantation in 2016 or 2017 and female recipient sex was associated with a reduced risk. It's not clear exactly what the sort of protective factor was that led to the time-based change there, like 2016, 2017, but It sounds like they couldn't find out anything additional to the fluconazole. So providing anti-mold therapy was associated with a lower early invasive mold infection risk, and then female donor sex was associated with a lower late invasive mold infection risk. Recent rejection was a risk factor for late invasive mold infection. And then renal replacement therapy predisposed patients to early invasive candidiasis, early and late invasive mold infection. So hard to know if that's a reflection of ESRD impacting the immune system, and or is it a marker of patients who have a complicated post-transplant course. And then interesting to see that there was no association between late invasive mold infection and anti-mold therapy in the study. But I think the decision on ongoing prophylaxis after 90 days was driven by the provider.
Okay. Well, I will wrap us up with a few. Moving into the parasitic section, be sure to listen to This Week in Parasitism. We're moving closer to this week. It's like this every other week in parasitism. The article, Variants of IL-6, IL-10, FCN2, RNase 3, IL-12B, and IL-17B loci are associated with schistosoma mannsonii worm burden in the Albert Nile region of Uganda, was recently published in PLOS NTDs. I'm always interested, so many people get exposed to schistosomiasis, but only certain people end up impacted. People who listen to TWIP may have heard mention of a boy with pretty severe schistosomiasis manifestations that I had seen a year ago. I actually just saw him again the last time I was there, and actually he's doing better. And this is a young man whose brother died from schistosomiasis. So there's something genetically going on there. At least that was the idea. And here, this genotyping was conducted on 326 children. They actually saw single nucleotide polymorphisms associated with worm burden, and really suggesting that immune balance, pathogen recognition, and Th17 pathways may be involved in modulating schistosoma worm burden, and that individuals carrying risk variants may be prioritized to improve control efforts. All right, still just the one drug, praziquantel, so we need to make some progress there. A nice review. I like this. Gastrointestinal Manifestations of Chagas Disease, a systematic review with meta-analysis published in the Journal of the American Society of Tropical Medicine and Hygiene. I like when they put a little bit of focus on the GI manifestations. Everyone always thinks Chagas heart, but particularly in Central America, we see an issue here, and they report that a meta-analysis showed a prevalence of gastrointestinal manifestations in individuals at 12%. In a subgroup analysis, the prevalence for studies involving healthcare services was 16%, while the prevalence for population-based studies was 9%. Megaesophagus and megacolon were the main forms of Chagas presentation in the gastrointestinal forms. And our last article in the miscellaneous section. We should have a This Week in Random Things, I guess.
Yeah.
But
yeah, I can't believe we actually haven't renamed our miscellaneous section.
The article, Large-Scale Releases and Establishment of W. Mel Wolbachia Aedes aegypti mosquitoes throughout the cities of Bello, Medellin, and Itagüí, Colombia, recently published in PLOS NTD. Now, the W. Mel strain of Wolbachia has been successfully introduced into Aedes aegypti mosquitoes, right? So we've got a particular type of Wolbachia. We pop it into the mosquitoes, and this has been shown to reduce the transmission of dengue and other Aedes-borne viruses. So here they report the results from phased large-scale releases of these Wolbachia-infected mosquitoes throughout 3 contiguous cities. Local Wolbachia-infected mosquitoes were generated and then released in an initial release pilot area in 2015-2016, which resulted in the establishment of this Wolbachia in the local mosquito populations. Subsequent large-scale releases, mainly involving vehicle-based releases of adult mosquitoes along publicly accessible roads and streets, were undertaken across 29 comunas throughout Belo, Medellin, and Itagüe, Colombia, between 2017 and 2022. In 9 comunas, there were supplementation by egg releases that were undertaken by staff or community members. By the most recent monitoring, Wolbachia was found to be stable and established at consistent levels in local mosquito populations greater than 60% prevalence, and in the majority, 67% of areas. Fingers crossed.
Yeah, and that brings us to the end of this Puscast. As always, the references for this show are available at microbe.tv, the home of our growing multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast. We'd love to get your questions, comments, and paper suggestions. Send them to puscast@microbe.tv. If you like what we do, if you don't like what we do, but you want us to keep doing it, consider supporting the science shows of Microbe TV at microbe.tv/contribute or Parasites Without Borders at parasiteswithoutborders.com and click on the donate button. We are right now in the middle of our doubling fundraiser.
Yeah, very nice. I'm Sara Dong. You can find me at swindong at Febrile Podcast or at febrilepodcast.com.
I'm Daniel Griffin, and you can find me at CUIMC or parasiteswithoutborders.com, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.